Welcome back to the deep dive. Today, we're really focusing in on a super important topic, pleural effusion.
Yep.
Think of this as your, fast-track guide. Really getting to grips with it. Perfect if you're revising or just need a quick update.
Exactly.
Really?
We're diving into what happens when you get this, abnormal buildup of fluid in the pleural space.
Okay, the pleural space. Remind us quickly.
Sure. So imagine your lungs, right? They sit inside these, thin sacs. You've got the visceral pleura stuck right onto the lung itself.
Okay.
And then the parietal pleura, which lines the inside of your chest wall. They kind of join up at the lung root, the hilum.
Mm-hmm.
Normally, there's just a tiny bit of fluid there, just enough to lubricate things as you breathe.
Like oil in an engine? Sort of.
Kinda, yeah. But with pleural effusion, you get way too much fluid collecting in that space.
And that's the problem, right? This buildup. Why is it such a big deal?
Well, all that extra fluid can actually squash the lung, which, makes it harder to breathe properly. That leads to those respiratory symptoms, poor lung function.
Gotcha. So our mission today is basically to pull out all the really crucial stuff about pleural effusion, the must-know info for understanding it and, importantly, remembering it.
Precisely. Let's nail the core definition again.
Yeah.
Too much fluid pleural space and the big umbrella causes.
In infection, inflammation, cancer, malignancy, right, heart failure, and liver disease. Those are the main headlines.
Good. Now let's dig a bit deeper into the why. The etiology.
Okay.
Under infectious, you're thinking things like pneumonia, TB, even fungal infections sometimes.
Right, and inflammatory.
That's stuff like rheumatoid arthritis, lupus, pancreatitis can even do it sometimes.
Okay, then malignancy, that's a big category.
Huge. Lung cancer, obviously. Breast cancer spreading there. Other cancers metastasizing.
Mm-hmm.
Heart failure is another major one. That's more about pressures being too high, causing leakage.
Like a plumbing backup?
Yeah, kind of. And liver disease, like cirrhosis, that can cause fluid issues too. Then you've got trauma, pulmonary embolism, asbestos exposure, even some drugs.
Wow, okay. Lots of potential triggers. Is there an easy way to remember the main groups?
There is. A useful mnemonic is IMHELTO.
IMHLT. Okay, break that down.
Infectious, inflammatory, malignant, heart failure, liver disease, trauma, other.
IMHELTO.
That's brilliant. Definitely one for the memory banks.
Stick it in there.
Okay, so we know what it is and why it might happen. Now, the fluid itself, I know there are different types, right?
Yeah.
Transudate and exudate.
Exactly, and knowing the difference is key.
So what is the difference?
Well, think of transudative effusions as being caused by a systemic issue, usually with fluid pressures. It's like a disruption in the body's overall fluid management system.
Okay.
So the hydrostatic pressure might be too high, pushing fluid out, or the oncotic pressure, the protein pull might be too low. It's fluid leaking out because of these pressure imbalances.
Right. So what causes that? Classic causes are heart failure, cirrhosis, really low protein levels, low albumin, and sometimes things like peritoneal dialysis.
So systemic issues causing leakage. Got it. And exudative.
Exudative is usually more about a local problem in the pleural space.
Ah. Oh.
It's caused by increased leakiness of the local blood vessels, often because of inflammation or maybe direct damage to the pleura.
So more of a local reaction.
Yeah. The pneumonia causing inflammation right there, malignancy irritating the pleura, a pulmonary embolism, autoimmune diseases causing local inflammation.
That makes sense. Local inflammation or damage makes things leaky.
Precisely.
And I've heard of chylothorax. Is that different again?
It is, yeah. That's a specific type where you get chyla, this milky, fatty fluid from the lymphatic system leaking into the pleural space.
Chyle.
Yeah, it usually happens if the main lymphatic vessel, the thoracic duct, gets damaged or blocked.
What would cause that?
Oh, could be a tumor, trauma, sometimes TB, sarcoidosis.
Parietal again, actually. Interesting. Okay, so we've got the types. Who's actually at risk of developing pleural effusion?
Well, several things increase the risk. Having a history of lung infections, for one.
Makes sense.
Chronic lung diseases like COPD definitely raise the risk. Smoking is a big factor.
Of course.
Exposure to things like asbestos or other toxins.
Yeah.
And then the conditions we've mentioned, cancer, heart failure, liver disease, autoimmune disorders, they all predispose you.
Right, so a lot of overlap with the causes themselves.
Exactly. The underlying condition is often the main risk factor.
Okay, let's get into the mechanism, the pathophysiology. How does this fluid actually build up? What's going wrong?
Fundamentally, it's an imbalance. An imbalance between how much pleural fluid is normally made and how much is drained away or absorbed.
Like a sink overflowing because the tap's on too high or the drain's blocked.
Perfect analogy. So with infection or inflammation, you often get increased fluid production because the capillaries get leaky.
Okay.
And sometimes the inflammation can also impair the lymphatic drainage, block the drain, basically.
Right. And what about cancer? Malignancy.
Malignancy can do both.
Yep.
The tumor itself can irritate the pleura and cause more fluid production, or it can block the lymphatic vessels, stopping the fluid from draining away effectively.
Okay, so blocking the drain again.
Yep. And heart failure, we touched on this. It's mostly increased pressure in the blood vessels, hydrostatic pressure, forcing fluid out into the pleural space.
The tap's on too high.
Kinda, yeah. And liver disease, especially cirrhosis with low albumin.
That's a low protein thing, right?
Exactly.
Yeah.
Low protein in the blood means lower oncotic pressure. So there's less pull keeping the fluid inside the blood vessels, and it leaks out more easily.
Got it. And the end result of all this extra fluid is?
Compressed lung. The fluid takes up space, squashes the lung underneath it, which leads to breathlessness and just, well, reduced lung function overall.
Makes sense. So clinically, how does this present? What signs and symptoms should make you think pleural effusion?
The big ones are shortness of breath dyspnea. That's probably the most common. And often a cough. Sometimes that cough comes with pleuritic chest pain.
That sharp pain when you breathe in.
Exactly. Sharp stabbing pain, worse on inspiration or coughing. That points towards inflammation of the pleura.
What else?
When a doctor examines the patient, they might hear reduced breath sounds over the area where the fluid is.
Because the fluid's blocking the sound.
Right. And if they tap on the chest over that area, percussion, it'll sound dull, not resonant like normal air-filled lung. Stony dull is the classic description.
Stony dull. Okay. What about more severe signs?
If it's a really large effusion or causing significant problems, you might see signs of actual respiratory distress. The patient's struggling to breathe, maybe using extra muscles. You might see cyanosis, that bluish tinge to the skin or lips from low oxygen, and their oxygen saturation levels might be low on a pulse oximeter.
Okay, those are definite warning signs. What about the patient's history? What clues might you get there?
Oh, loads. The size of the effusion often correlates with symptoms, so asking about how breathless they are is key. Unexplained weight loss, that's a red flag for
Malignancy.
Right. Smoking history, cough and a blood hemoptysis points towards lung cancer potentially. You always need to ask about past medical history, medications they're on, and their job, any asbestos exposure.
Yeah, crucial for mesothelioma risk.
Definitely.
And the physical examination itself. What specific things might a doctor look for or find?
Well, on inspection, just looking at the patient, you might notice weight loss, other signs of cancer perhaps, nicotine stains on the fingers.
Clubbing.
Dabbing. Yeah, that swelling of the fingertips can be linked to lung cancer or other chronic lung conditions, maybe signs of rheumatoid arthritis in the hands. You'd look at how they're breathing. Are they dyspneic? Is one side of the chest moving less than the other?
Okay.
Then palpation, feeling the chest. You might feel reduced expansion on the side with the effusion. If it's a massive effusion, the trachea, the windpipe, might actually be pushed over to the opposite side. And you'd feel decreased vibrations when they speak. That's reduced tactile fremitus.
Right. And percussion.
Stony dullness, as we said. Often it's highest in the axilla, the armpit area.
And auscultation listening.
Diminished or completely absent breath sounds over the fluid. But interestingly, right at the top edge of the fluid, you might hear something called egophony.
Egophony. What's that?
It's where if you ask the patient to say E, it sounds like a bleeding A through the stethoscope. It's a bit weird, but quite specific for that fluid level interface.
Huh. Okay. Lots of potential clues there. So you suspect an effusion based on history and exam. How do you confirm it and figure out the cause? Diagnostics time.
Right. First step is usually imaging. Chest X-ray is often the starting point, or an ultrasound right at the bedside. Both can show the fluid, give an idea of size and location.
Ultrasound's quite good for guiding procedures too, isn't it?
Absolutely. If you need a more detailed look, maybe to find the underlying cause like a tumor or infection, then a CT scan or sometimes an MRI would be next.
Okay. But the definitive thing is getting a sample of the fluid.
Yes, thoracentesis. That's putting a needle into the pleural space to draw some fluid.
Sounds a bit risky.
It has risks, like pneumothorax, but using ultrasound guidance makes it much, much safer and more accurate. Usually done with a fine needle, maybe a 21 gauge and a syringe. You only need about 50 milliliters for the basic tests.
And that fluid goes off to the lab?
Yep, for a whole battery of tests. They'll check the pH, protein level, LDH, lactate dehydrogenase, cell count, cultures for bacteria or TB, glucose level.
And that's where Light's criteria come in.
Exactly. Light's criteria are really the cornerstone for figuring out if it's an exudate or a transudate. It's based on comparing the protein and LDH levels in the pleural fluid to the levels in the patient's blood serum.
Okay, remind us of the key points of Light's criteria.
So generally, high protein in the pleural fluid, say over 30 grams per liter, points towards exudate. Less than 30 suggests transudate.
But it's not always clear-cut.
No, there's a gray area, maybe between 25 and 35. So then you look at the ratios. If the pleural fluid protein divided by serum protein is greater than 0.5,
Exudate.
or if pleural fluid LDH divided by serum LDH is greater than 0.6,
Exudate.
or if the pleural fluid LDH is more than 2/3 the upper limit of normal for serum LDH.
Exudate again. If any one of those is met, it's likely an exudate.
You got it. That helps narrow down the potential causes significantly.
What other things might the fluid analysis show?
Well, very low glucose can suggest rheumatoid arthritis or TB. High amylase might point to pancreatitis or maybe an esophageal rupture.
Okay.
If the fluid is bloody, you have to think about malignancy, particularly mesothelioma, but also pulmonary embolism or TB can cause that.
An infection, if it looks like pus.
Yeah, if it's obviously purulent or cloudy, that's empyema. But even if it's clear, the pH is very low, less than 7.2, that usually indicates infection or significant inflammation, and typically means a chest tube drain is needed, not just aspiration.
Right, need to get that infected stuff out. Are there specific guidelines, like from the BTS?
Yes, the British Thoracic Society has detailed guidelines. They talk about different approaches depending on whether the effusion is one-sided or bilateral, the clinical picture, the fluid appearance, and recommend further tests and imaging based on those initial findings.
Okay, so Light's criteria is key, but you look at the whole picture appearance, pH, glucose, cells.
Absolutely. Cytology to look for cancer cells is crucial. Sometimes they measure cholesterol or triglycerides if chylothorax is suspected. And the white blood cell differential can give clues. Lots of lymphocytes might suggest malignancy or TB.
Right. So once you have a diagnosis, or at least a good idea of the cause, how do you manage it? What's the treatment plan?
It's really tailored to the individual. Depends entirely on the underlying cause, how bad the symptoms are, and if there are any complications.
Makes sense.
The main goals are always relieve the symptoms, especially breathlessness, treat the root cause if possible, and try to prevent the fluid from coming back.
So what are the tools?
Well, medical therapy first, antibiotics if it's pneumonia, diuretics if it's heart failure related,
Okay.
then procedural interventions. Simple drainage with thoracentesis might be enough for symptom relief. Or if it's larger or infected, a chest tube might be needed for continuous drainage.
And if it keeps coming back, recurrent effusions.
Yeah, that's often a problem, especially with malignancy. Options then include repeated aspirations, which isn't ideal long-term, or a procedure called pleurodesis.
Pleurodesis, sticking the pleura together.
Essentially, yes. You drain the fluid, then inject an irritant substance, often talc or sometimes tetracycline, into the pleural space. This causes inflammation and scarring, which sticks the visceral and parietal pleura together, obliterating the space so fluid can't reaccumulate.
It's uncomfortable.
It can be.
Yeah.
Usually done for recurrent malignant effusions where life expectancy is limited, but symptom control is important. Another option for recurrent effusions is an indwelling pleural catheter.
Like a long-term drain.
Exactly. It stays in place, tunnels under the skin, and the patient or a district nurse can drain off fluid periodically at home. Gives patients more control.
Okay. And sometimes surgery.
Less common, but yes.
Yeah.
Things like VATS, video-assisted thoracoscopic surgery, or even a full thoracotomy might be needed for complex cases, like severe empyema or decortication to remove thick rind from the lung.
Got it. So thinking about the longer term, what's the prognosis like for someone with pleural effusion?
It's really variable. Hugely depends on the cause.
I guess if it's caused by something easily treatable, like pneumonia.
Exactly. If the underlying cause is treatable, like an infection that responds to antibiotics and it's managed quickly, the prognosis is generally good.
But if it's something like
Advanced cancer or a severe heart or liver failure, then the prognosis is often dictated by that underlying condition, and the effusion itself is a sign of advanced disease, so less favorable.
Right.
Also, if it's left untreated or if complications develop, that worsens the outcome.
What kind of complications are we talking about?
Well, infection of the fluid turning into empyema is a big one. Fibrothorax, where the pleura gets really thick and scarred, trapping the lung.
Which would restrict breathing long term.
Definitely. Respiratory failure can occur, especially with large effusions or underlying lung disease. Pneumothorax is a risk from procedures like thoracentesis, and of course recurrence of the effusion.
And specifically for malignant effusions.
Yeah, unfortunately, a malignant pleural effusion is generally a poor prognostic sign. It indicates the cancer has spread. Median survival can be quite short, often measured in months, maybe 3 to 12 months on average, though it varies. Complications also include further metastasis and cancer progression.
So the cause is really paramount for prognosis.
Absolutely critical.
Okay, let's just quickly recap the main potential complications again.
Sure. So, infection empyema, fibrothorax, that thick scarring, respiratory failure, pneumothorax, collapsed lung, recurrence of the effusion itself. And with malignant causes, you've got the cancer progression and poor overall prognosis. Even chronic pleural thickening can cause long-term symptoms.
Okay, that's a comprehensive run-through. So to tie it all together, pleural effusion is that abnormal fluid in the pleural space. We've talked about the causes. Remember, I am HELTO.
You have infectious, inflammatory, malignant, heart failure, liver disease, trauma, other.
We covered the types Transudate versus Exudate and how Light's criteria help differentiate them.
Based on protein LDH.
We looked at presentation, the diagnostic steps like imaging and fluid analysis, and the management strategies from simple drainage to pleurodesis or catheters.
Covering the whole spectrum.
It's definitely core knowledge, isn't it, for anyone working in medicine?
Absolutely essential. Getting the diagnosis right, understanding the cause, choosing the right management, it makes a huge difference to patient outcomes.
And for all of you listening, especially if you're prepping for exams like the MSRA, really make sure you've got these key points down.
Definitely high-yield stuff.
And don't forget, for top-notch revision resources, check out passthemsra.com and also freemsra.com. Loads of great material there.
Great resources.
Finally, just something to think about. We've talked about this delicate balance of fluid in the pleural space. When it goes wrong, it causes significant problems for something as fundamental as breathing. It just highlights how intricate our bodies are, doesn't it? What other processes, maybe ones that seem simple on the surface, actually rely on such complex, finely tuned mechanisms? Something to ponder.